Hi, I'm Justine.
And I'm Sarah Levon.
And we are so glad you're here.
We believe that your life has the potential to make a deep, meaningful impact on the world around you. You, as a nurse, have the ability to add value to every single person and patient you touch.
We want to inspire you with resources, education, and stories to support you to live your absolute best life, both in and outside of work.
But don't expect perfection over here. We're just here to have some conversations about anything birth, work, and life, trying to add some happy to your hour as we all grow together.
By nurses, for nurses, this is Happy Hour with Bundle Birth Nurses. Welcome back to Happy Hour with Bundle Birth Nurses. Today, we're going to talk about something that I get asked all the time, whether it's in DMs or on mentorship calls or in person with preceptees, and it is tips for how to check a cervix. I understand why I get asked this all the time, though. It took me months to find a cervix, and then months after that to feel comfortable with finding a cervix all the time. I'd say it was probably about 6 months.
Whoa, that's a lot.
Total, including the 4 months of training. So then 2 months on my own where I felt like I didn't need to always ask for a check behind. I was so concerned.
Do you remember the first time you checked a cervix?
I can't remember the first time I checked a cervix.
Or like you found it?
But yeah, I remember the first time I found a cervix. There's actually 2 stories I can think of. The first time I found one, I was so excited that my preceptor took her hands out and she knew, like, she smiled at me like, there's no way you're not going to find this one, Justine. And when I felt it, I was like, oh! And the patient was like, what? And I was like, you have the most perfect cervix. Like, I felt it. It was 4. It was like 80%. It was right there, super anterior, bulging bag. It was so perfect. And then another time on orientation, the first time I really understood effacement, I remember my hands were in there and I was like, the preceptor was like, what do you feel? And I was like, it's thick. Like, she feels thick. And my preceptor was like, yeah. Like, I was like, yeah, she's like, that's like, 30, 20%. Like, it's super thick. I was like, yeah, it's super thick. Like, I get it. And then I look at the patient, he was laying there and I was like, do you know what we're talking about? And she was like, well, like, I know I'm pregnant.
Again, choice words.
Right. Early on, I'm like, oh, it really matters what we're saying. But what about you?
I remember like anticipating checking a cervix because I don't know about you, but like in nursing school, I never checked anyone.
No,
and so it was like once I was a nurse. And I knew this was coming, but I was like, there was like a little bit of anxiety of like, I'm putting my fingers in someone's vagina. Like that's a skill that's like, I knew in my mind would eventually become very comfortable, but it was not totally comfortable from the beginning. And I remember being like, it's just a lot of mush in there. Like, I feel just a little lot of smushy. And then I remember very vividly the first time I found it. I don't know how long it was in. It wasn't too far in. Like, I'd probably checked 10 cervixes at one point, but I remember like kind of digging around and like, and then my finger like slipped in the hole. And I was like, it's a hole. Like, there's like an actual other hole in there. Oh my God. Yeah. And like, she was 1 centimeter. And I was like, oh my God. Like, I'm looking for a hole. That's what I'm looking for at the end of the vagina. And then once I sort of like could picture the anatomy in my head of like, I'm going to the end of the vagina and then digging around for a hole, like that like made sense to me.
Yeah.
And then, it was like, when my fingers could separate, what is that? Like, there was that skill after you sort of just like find the cervix. So I found the cervix, but then it took, Lord, a whole lot of cervixes before I felt like, oh, okay, I got this.
No, totally. I honestly, actually, I'm glad you said that about understanding, like visualizing the anatomy, because it wasn't until I was pregnant and I asked my husband to check my cervix where I was describing to him how to check a cervix. And he was like, well, yeah, it's like a bowl. Your uterus is like a bowl and I'm looking for a hole. Like, I'm scanning the bowl for a hole. And I was like, yeah, that's a great way to put it. And so
like the bowl is sitting like at the bottom part.
Yeah. So like you go
like the lower
vagina,
uterine segment.
Yeah. It's like a bowl and you're finding the hole. And I was like, yeah,
bowl in the hole.
Great. Why didn't I ever think of that? And he found my cervix the first try. And I was like,
hole
okay,
in the bowl. That's going to be our new hashtag. Hashtag hole in the bowl.
So we want to talk a little bit today about our tips on how to find a cervix. And I'm going to go through just like basic tips and then we'll share what we've learned along the way.
Maybe like what did you explain to your husband? Now I want to know, like if he found the cervix the first time.
Yeah. So I just said, so I remember I was like, okay, so put two fingers and then you're going to go, you have to get through my vagina. And I don't think we think about
Through it.
that, right? Right? To get through my vagina. You have, well, what's a better word for that? I don't know. So you have to
All the
pass through the
way in.
vagina.
Like you can't be just at the hole. You got to like get up in
Right.
there.
Get up in there. And I think that sometimes, so a little tip, sometimes I feel like when you're new, you go into the vagina a little bit, maybe 2 inches, and you meet
Mm,
resistance because it's tighter. And then you spread your fingers open and you're like, oh, I can only spread it this
mm.
much. She's two,
Yep.
but they're not through the vagina yet. So they have to get
Through the
through the
vagina.
vagina, bowl in the hole through the vagina.
We're
Uh,
finding the bowl, the hole in the bowl.
so you have to get through past the vagina and to like an open space, right? So once you get past the vagina, you have more space to like open your fingers up because
Mm,
there's the bowl there, but below the bowl is a little bit of a space. And then I was like, personally, I like to go towards the back then and then
yeah.
scan
Mm-hmm.
my way forward.
Mm-hmm.
So for anyone listening, so I go, my two fingers are through the vagina, I reach the space, then I reach back.
You're kind of scooping your fingers
Yeah.
under, like going towards the posterior side of the patient. Like kind of, and what I would say is I'm imagining my fingers touching the vaginal wall on the, like, because my fingers are
Bottom side.
facing up, my
Yep.
fist, like my two fingers facing upwards. And for sure, I'm pressing the vaginal wall, not pressing hard, but like touching it on the back part of my fingers
Yeah. Good.
all the way to the back. The other thing I would add here is like that was helpful for me was you're looking for the end of the vagina. Like if you go in and you're not hitting the end, like imagine like a tunnel with a door at the end. And
Yep.
that's the hole in the bowl. Oh God. I hope we don't lose you, but stay with it. That like you're looking for the end of the hallway that is the hole in the bowl that's opening, right? And if you're in the hallway's not 2 inches, the hallway's likely the entire length of your fingers and maybe more. That's why you see a provider like press on the top of the abdomen, or you have them sit on their fists if they're comfortable, or you put down the end of the bed to tilt the pelvis because it shortens that length of the vagina and brings the cervix forward, the hole in the bowl. I'm
I
never
love
gonna
it.
stop.
I love the hallway now too. Like the
Yeah,
hallways
you're
to the
going
hole in the
down the
bowl.
hallway to the end of the hallway till you hit the door, and the door is either cracked, it's a hole in the bowl.
Uh-huh.
It's either cracked up to 10 centimeters and wide open, and then you're gonna hit the baby.
So how would you describe then like a posterior? Because then you're like
I mean,
turning down the hallway.
it's like where's the door opening from?
Yeah.
Is it like just wide open, splitting down the middle, like it's two sliding doors opening in the middle? Or does it crack left or crack right? And normally it's going to crack if you're facing the hallway to your right side. Like, right? That like you scoop under, or like under,
Yeah.
I suppose. It's
Yeah.
not
Yeah.
on the front. But I would say that that's like the right side of my head. I feel like we've probably lost people at this point. Let's backtrack.
Yeah, we're
But
gonna rein it in.
if you're a metaphor person, think hallway to door. Where's the sliver in the door? Like the door is either it's either closed and
Yep.
you dig around and you can't find an opening in the door or the hole, or you're searching for the
Hole
hole
in the bowl.
in the hole.
I love that. I hope that someone's listening and so annoyed with us right now, but it's okay. Hopefully that was helpful for a lot of people.
Well, and a posterior cervix is the whole point of when you're going in. Most of the time, like the cervix starts posterior, and then as the baby comes down, it becomes anterior. And then instead of looking for the hole, a lot of times you're actually looking for the baby's head. So you may go in and you're feeling around and you're like, whoa, round, hard softball in here. And then once you find that, you're finding the hole on the head,
Yep.
because you may hit resistance where you're like, whoa, that's a head.
Yeah, if you're
You know?
you're feeling exactly the softball is the uterus essentially, right? You're feeling the uterus, baby's head's inside of it, and now you have to find the hole.
Yeah. That's
Where
like a lot of times pressing up in the bowl, like it's flush with the uterus,
Yeah.
right? And then you may feel the head and feel that resistance, or the vagina, you checked it 3 hours ago and the vagina was much longer than it was now because the baby has now come down. So now you're hitting the end of the hallway. It's like you've walked halfway down the hallway already
Uh-huh.
because the doors come closer to you.
Yep. No, I like that. And then that actually gives me a good segue to say if you're hitting baby's head, but the cervix is posterior and you're having to go all the way around to get to the cervix.
And it's a scoop. By posterior, it's like your fingers are on the bottom part of the vagina towards their sacrum. And then you're going all the way back on the tissue, feeling the smush till you hit resistance, and then sort of sweeping your fingers forward across that resistance. So it's like you're running your fingers across the door, or you're
From
running
left to
your
right.
fingers
Mhm.
from like the bottom up top or left to right,
Yep.
right to left.
Yeah.
It's on their left side, but like if we're facing the vagina on our right side.
Yeah. And to remember that just because you felt like you went in farther because it was a posterior cervix doesn't mean baby's -2, -3.
Mm.
Because remember, you had to pass the baby's head to
Yeah.
get around it. So
And like
baby's lower than you
scoop
might
around the
think.
baby's head.
Yeah. Yeah. I think we forget that sometimes.
Mm-hmm.
Okay. So that's the idea of like making sure you get through the vagina. What is the vagina length? It's like 2.5 to 4 inches, an average vagina length.
I think like 4.
Like Sarah said, as the
Yeah.
baby comes down, that hallway gets shorter. And then you're scanning for a hole. I like to say that a closed cervix feels like a Rolo. Some people will say
Oh,
too,
yeah, I've heard
like
that.
half a centimeter or 1 centimeter is kind of like a Cheerio. Maybe half a centimeter is like a Cheerio. You can't really get your
Mm-hmm.
finger through, but it's a little bit open.
You find the little
And
nubbin, the
yeah,
little, and then you're like, ooh, there's actually space in there. It's not a Rolo. It's not closed.
yeah. And I will say that I recommend checking on yourself if that's something you're comfortable doing because you can feel a closed cervix if you're not
Slash a
pregnant.
divot. I've checked mine and I have a divot.
You have a divot, yeah? Did you check closer to
Yeah.
your period, I wonder? Because their cervix opens up a little to release
I mean, I didn't
blood.
check on my period. That's weird.
I mean, like before maybe. But
I don't know.
a tip it would be to check it a little bit before your period because the cervix comes forward closer to our period. So it'll be a
Oh.
little easier for you. But everyone out there,
Oh.
find your hole in the bowl.
Slash, for me, it's like I have like a nubbin in there. Like, and actually, if you look at like speculum pictures, the cervix like dips out. It's not flat. It like pops out like a
Like a Rolo.
bigger than a Rolo. My
Yeah,
cervix
that's
is
true.
bigger than a
That's
Rolo.
true.
These
Mine's a
are
little bigger.
intimate details about our cervixes on this episode.
So yes, check yourselves if you can and you feel comfortable with that. So
What about
yes.
station?
Oh,
Station's the one.
Station is the one. I want you to go over station because I feel like you're more confident with station than anyone I've ever met in my life.
What?
And you have that really good cheek analogy. If you feel comfortable.
Oh,
sharing.
yeah, the cheek.
Yeah.
Okay. So our 3 components, there's really 5 components of a vaginal exam, but we'll go with 3 for now, right? There's dilation, which we just talked about. Effacement is the thinning. So one of the ways that I've learned along the way, if you look at the space between your pointer finger and your thumb, so everyone look down and stretch your fingers wide. There's that skin between them. Feel that skin. That is what you're feeling if your fingers were to go alongside, and feel on the side of your fingers to feel for how thin that skin is. This is like 90 to 90-ish percent effaced. 100% effaced. I'm going to station. I just got very distracted with effacement. It's like paper thin.
Yep.
Okay, so paper thin, almost not even there sometimes, is 100% effaced. We know the thinner they are, the more stretchy the cervix, typically a lot faster that they'll dilate. So you feel there as like a thinner cervix, so you can sort of gauge, like we're looking at how thick or thin it is, and then you can find other areas. Like I'm like, my nose is like probably still 90.
She's picking her nose right now.
I'm kind of picking my nose. Or like, I don't know, my lip. Like every lip is gonna be different, but like this is probably like 70. Like the like width of my lip here.
Earlobe's popular.
Earlobe. Ooh, earlobe for 80. And then thereafter. So one of the ways that I also would teach when I'd precept, when we'd be sitting around the nurse's station, is I'd grab random things at the nurse's station and have them close their eyes and like put their finger. So I have like a mug here, and this is like 6.5 to 7 centimeters. And then you check that way, or the top of a water bottle I have here, and that would be like 2 to 3. And so you can kind of like feel things around your house and then take a tape measure and see and guess like based on how open or closed you are. You can practice that way. Once you get this stuff, it is like riding a bike.
Yeah,
Like
for sure.
you have to think about it, but I'm like, that's 4. Like we're good, So thinness is or effacement is the second component, and then station is how high or low the baby is based on the ischial spines in the pelvis. Okay, so you have to know the anatomy of the pelvis. We talk about this in physiologic birth. Grab a pelvis on your unit. I hope you have one. If you don't, talk to your educators about it. Maybe they have one in their office you can look at. Because in the pelvis, I think, I don't know, I was feeling pubic bone for a while. Like I thought ischial spines was the pubic bone or the pubic symphysis on the front part. It is not. It is on the sides, the lateral sides of the vagina. When you're in there with 2 fingers, just move your hand left and right. Once your fingers are all the way in. And what you're feeling for is any kind of firm resistance. It's not pointy, but it is a firm, like nubbin, to use like non-technical terms, sticking out on the side of your fingers. In some pelvises, like you'll be able to wiggle your hand left and right and kind of push for those bones pretty significantly. Like you have a lot of space. You've heard people say this. Or you reach and like those bones are like right on the sides of your fingers. Does it make a difference for whether or not baby can fit? Maybe, but probably not, because all of this moves, it shifts in labor. It depends on so many different components, okay? We don't want to get that in people's heads when you're like, oh, there's not enough space, And we hear that a lot. So, but what you're feeling for is if you stick your tongue on the side of your cheek, like you're pushing out, and feel for what that nubbin feels like, right? And so put your fingers up next to it. Like if you push against your cheek without your tongue there, it feels smushy. That's like the vaginal wall. Now push your tongue up against your fingers, and all of a sudden there's like a knob
I'm envisioning
or like a little
doing
bump.
this.
I hope so. We are. We're gonna have to make an Instagram post about it to like show you what we're talking about in this episode. But you sort of get the idea that like instead of it just being smushy, you're feeling for that resistance on the side. And based on, so your fingers are touching the top of baby's head. If you can't reach baby's head at all, no matter how hard you try, or you can't reach the cervix at all, we're like a -4. Most of the time in labor, if you push, by push, I mean like reach far enough inside, you can touch the baby's head. That's probably a -3 to -2 is like you can feel it, but it's still pretty in there. Now, if we're actually being technical about this stuff and doing it right, we have to measure where our fingers, the tips of our fingers are touching the top of baby's head. And then from there, where are the ischial spines? So where's that little nubbin on your cheek? If you push your fingers are touching the top of baby's head, or at least like the cervix that's in the way between the baby's head, right? So there's resistance. And then you're moving your hand just a little bit to the left or the right to hit the ischial spines. And where do they land on your finger? And we're thinking finger breadths. So if it's 2 finger breadths, and you can literally put your 2 fingers together to cross them, if it's 2 finger breadths that the bone is hitting below, so like on your knuckle, then you're -2. If now, all of a sudden, the baby's head, you move your fingers out a little bit more, and the nubbin is 1 on your very first knuckle, so like the first bend in your finger, that's -1, right? Or 1 finger breadth. Or if you are touching the baby's head and you move it left and right, and the bone is right there, like it's on the tip of your finger, you're at 0 station. Does that make sense?
Yeah, I think it's great.
And then you're going towards positive station. So you go up and you're like, these bones are not on the sides of my fingers, actually, the head. And you're going to know this because you're not going to have to reach as far inside the vagina anymore. And so the head is like, oh, it's right there. And you'll kind of like, oh. And then what you're going to have to do is likely sweep your fingers around the edge of baby's head to feel for that resistance or that bone. Now, when you're pushing, a lot of people start pushing at 0 + 1. And +1, keep in mind, is not like a lot of the baby's head past the bone. It's 1 finger. So look at the roundness of your head in the mirror and put 1 finger down. There's still like a lot of the width of our heads, or you could do this on a baby doll too, because there's still a lot of head still up past the bone, but it's trying to come through versus it's floating in the pelvis. And by floating in the pelvis, everything is oriented to those ischial spines. You need to be able to envision this in your head, whether that be with a picture or a pelvis model. You can look on our position guide. We have like models and stuff in different ways that you can see where this is for station. And then you start coming through. Once you can see the head, they're +3. You don't have to check that.
Do you think that have you ever found your own ischial spines?
Oh yeah. Oh yeah. Go in and dig around in there. Get up there.
I'm gonna do that.
Yeah. Yeah.
That's what I'll be doing after this episode.
Well, and you're not, and in that case, you're going to be a -3, -4 / like there's going to be no resistance inside unless you're pregnant and you haven't told me already, you know? And so, shocker.
You're like, are you?
I'm like, I waited. That was my subtle way of asking if you're pregnant.
No.
But otherwise, you're not going to hit that resistance. But when you're in there with 2 fingers, just move your fingers left and right and feel like you can even turn your hand, because no one cares. It's your vagina as long as you're comfortable with it, and press until you find what that nubbin feels like. That's a great idea. I've never like intentionally been like, I'm going to go look for my ischial spines tonight, but now I might.
Well, I think that was really helpful. And like I said, I'm going to be going to find my ischial spines.
I think I will too. My nails are really long right now, so I'm going to be really careful. I'll put a glove on.
Everyone always comments that. Like when you show your nails with anything, they're like, I hope you're not actually checking cervixes like that. And you're like, I'm not.
How many times do I have to disclaim this? I like literally my intro video for my YouTube channel. I'm like, okay, here's 5 things to know about my channel. One is I'm not checking cervixes with these nails because I like the DMs and like that is unsanitary and blah, blah, blah. I'm like, the perks of not working in the hospital means I can have really cute nails all the time.
Right. Okay, so those are kind of the basics of finding. And then the other 2 things I'm assuming you were going to say, Sarah, about the other 2 parts of the cervical exam are going to be the consistency of the cervix. If it's firm, soft, moderate is what we go by. And then if we talked a little bit about it, posterior, midline, anterior. Mm-hmm. So those are all parts of the Bishop score and like the big picture. The last couple years, especially after like learning everything I have with Sarah, I've really considered like dilation is not a big deal to me in my mind anymore. It's more how soft they are, how effaced they are, and where baby is. And so I think that comes with time, because in the beginning you're just so excited about finding that dilation. So
well, and it's how you respond too, because so often from a patient perspective, they're thinking like what they hear is dilation. Every story they've heard, I showed up to the hospital at 4, I showed up at 6, I was 8 centimeters when I got my epidural. Like no one's saying I was 100% effaced when I got my epidural. You never hear that. Or like my baby was 0 station. Like that's not what's heard.
Or even the doctors don't even tell them that.
They're just like 3. You're 4.
Right.
Yep. And I'll be virtual with someone. I'll be like, I need more information. Can you ask for the full exam? Yeah. And so I think for us to give the full exam, give the full picture, they've maybe done some of that education. And then also to note that how we respond when we're telling what they are really does matter, because they could be 120 when they arrive in triage and 2 hours later be 190. And you're like, you're still 1 versus you're 90% effaced. Right. That's massive change. And honestly, from my perspective, I'm like, I'm way more excited about that exam than I would be 20% effaced and 3 centimeters. Like I'd be like, oh my God, go home.
No, that's so true. And that brings up a good point of you're only 1. We really like to take, and we teach that a lot of mentorship, to take that out of our vocabulary, or you're still 1. Mm-hmm. Those can be really impactful. And I think you learned that really being on the other side, right? Because you're hearing it from your clients and how defeated they are.
Yeah. And they walk out the room and they're like, oh, I'm like, no, we are 1. We are 1 centimeter. We love 1 centimeter. Mind you, it's been a very long time since I've been in the hospital with a 1 centimeter patient if they're not being induced. So like now we're 1. And now guess what? We rule in for a Foley balloon. That's exactly what we were looking for an induction. Or, you're 6, you're still 6, great. But what are the positives? Look at your contractions. Look at your effacement. This baby's coming down. Your own sensations, you were like chilling 2 hours ago, and now we're huffing and puffing. Yeah. There is progress. It's not just dilation. It's big picture. Note their progress, because it's easy to feel defeated. It's easy to sort of throw your hands up and be like, ugh, fine.
So true. That's great. On the same line too, you have your patient that comes in and, they were closed in the office and they are one now. And so they're really defeated. You could be like, your body's doing it. It's starting to do it. I learned that from you of like, it's starting to do it. And that's amazing and great. You came in, you got checked, your baby's doing wonderful. And so now we know like it's starting, and it could be really hopeful for them.
Well, yeah, and that it's celebrating the baby steps, especially for somebody who thinks they're in early labor and you're sending them home. The number of times, and I heard it as a nurse, I hear it as a doula, I hear stories about it later, and it's the like I came in and I was like really working hard and like really excited to like show that I was doing it, and they're like, "Oh, you're not even in labor, go home." Like just like I just said, which I wouldn't ever say to a patient. Right. But like, oh no, like, girl, it'll be days. You can just go home. Go home. You'll feel so much more comfortable. Like, it's fine. And yet inside, it can feel really like, what? What do you mean go home? I'm working so hard already. And so that's where that compassionate side of nursing, of meeting them where they're at and really empowering them with like, and really what I would say in that case is do the education of like, you're 1 centimeter. This is amazing. Your body is starting up. Your hormones are shifting. Look at these beautiful contractions. Look how perfect your placenta is. This baby is thriving inside of you. And so right now, and you can show your finger, your cervix is this dilated. This baby's not going to fall out of you. Things are brewing. But at this point in early labor, we don't know how long it's going to take. You could be back here in 3 hours. You could be back here in 3 days, and they're like, what, 3 days? I'm like, who knows? Flex and flow, and all of that is beautiful. Your body is unraveling. Your cervix is dilating. This baby is coming. But that's sort of that, like, let's hold loosely to how fast or how slow. All you have to do is 1 contraction at a time. You give them some coping tools. You give them some information. You tell them what they're looking for to come back. And then the other trick here that I'm going to give that I totally forgot about, that I say a lot, is that this is now, what your baseline is. So what your sensations are right now are not active labor. So if this continues like it is, even if it intensifies a little bit or it kind of goes back and forth, remember irregulars, early labor, you learned that in my childbirth class, that then even if it continues, we know it's not time to return. What we are looking for is a significant change in your sensations. So right now, you have a baseline, and we know that what you're feeling right now is 1 centimeter dilation sensation.
I love that. I'm like listening to you like, oh yeah, that's great.
I say that a lot.
With the baseline. I love
it's
that.
It's a baseline. And it sort of reframes the education. It reframes even them feeling like, oh my God, I feel so ashamed I came in too early. No. What a beautiful opportunity for you to receive some education, get some more information about what's going on, and then feel even more confident to go home and enjoy your environment. Go get a snack, walk it out, get your nails done, like watch a movie, grunt and groan, take a shower. And we'll see you soon, and that's what you leave them with. That is so much more hopeful and empowering than you're not in labor, girl. You got so much time. Don't even worry about it. Like, you're doing great, but like, it's not time yet. Just like, go home and rest. Like,
it's really hard to rest.
Like
when they're working so hard.
I'm moaning through these contractions. Right. Yeah.
That's a great point. Something we haven't talked on this, and we're really big on this, and we're really into this episode, and I'm sure you know what I'm talking about, is asking for consent for cervical exams. And so I don't know about you, but I was taught that I'm going to perform a cervical exam, or it's time to do a cervical exam. It wasn't taught to me to ask. Yep. It was, they're here. Obviously I have to check them. They have no choice kind of mentality. And so I love that, like the dial is turning on this. Is that the right? I don't think that's the right saying.
Sure.
You're the wrong person to ask for that.
I am the wrong person. I am the worst at / the best at messing up idioms. Because I always say I'm a foreigner. I'm a foreigner.
Like, I don't know what they are.
I'm just trying to fit in.
So I'm really bad at them too. But it is so easy to ask for consent and should be the norm. It takes the same amount of time to say, is it okay if I check your cervix now, versus it's time to check your cervix now.
Well, and I think this practice change has been happening. We've been talking about this. Like, you all should be like, duh, at this point, if you've been following us or like doing any kind of education with us, we are always asking for consent. And the answer, they may look at you like, yeah, like, duh, why are you asking? but keep asking because
Please.
they are
Yeah.
right. I mean, they are paying attention and they're noticing it, and it feels better than feeling violated when you are touching a place that very few people touch. They need to tell you it's okay, right? And regardless your gender, that still consent needs to happen. And what I do,
Yes.
this, you know what I was thinking back, because when you said we were going to record this episode, I was like, huh, where did I learn that tip? And it was directly
Mm.
from Penny Simkin. She
Mm.
came down to my hospital and did grand rounds and then did a session on dystocia related to like labor dystocia
I
related
didn't
to,
know she went to your hospital.
she like spoke at our
You
hospital.
also saw Michelle O'Dent too.
Yeah, I did. That was
Been
at another
around.
event. I know, it's
That's so
LA. We're
cool.
so
You're
spoiled. I
so
know.
LA.
I am so LA. And so,
Anyways,
but
sorry.
this was I was a per diem nurse at this hospital, and I like had read there was some like labor forum thing. It was free, and like some big person was coming to speak. This was before I did any kind of childbirth education. This was like very early in my career, and I saw Penny Simkin speak, and I remember being like, ding ding ding, oh
Mm.
my god, I need to ask for consent. And then she taught, I think she taught, somebody taught early, this was probably a year and a half in, and it was when you get them set up, talk them through before their legs are spread, before you've exposed them, and say, hey, how do you feel about a vaginal exam? You know, or by vaginal I mean cervical. We get a lot of
You're
flack for
very upset
either one.
about this.
Like it's a VE, SVE. That's that cervical, same. But when you're checking the cervix, that you would ask for permission and say, how do you feel about it? Here's the rationale behind. And then they go, yeah, great. When they give you that, then you talk them through what to expect. Maybe some tips. Let me tell you that, like, you know, like if you ever say stop, it is a stop, and that we are respecting their stop and their no. If they're running up the bed, we've all seen this. If they are running up the bed, remove your hand. Whether they're telling you stop or not, if they are resisting and pulling away, we need to respect their autonomy over their body. There is body language communicating it's not okay. They may say, no, keep going. Take your hand out and let them relax and come back to another consent. And so with that, she would say, like, you know, like have them open their knees. We are never forcing knees open. This is also the person who wrote When Survivors Give Birth. I actually did that instructor training. I just need to go through the certification. Then a class is coming for you when I can get my head around it, because it's a huge area of passion for me. And so, you know, that you let them open their knees and then you get ready and you say, okay, you tell me when you're ready. And they may say, yeah, go. Or they may say, and you'll notice this the more you do this, they may be like, okay, give me like a second. Okay. Yes, I'm ready. It may take a moment, and that's okay, but we are respecting their body autonomy in that way. And then the other tip that I think it was her, it's been so long now, but was like, okay, you're going to feel my touch on your leg closer to your vagina. I'm inserting my 2 fingers, and then you're not staring at their vagina. Once your fingers are in, it is a blind exam. Please like look away. Some people, it feels awkward to make eye contact. You're like, I'm staring into your eyes. That's weird. You know, look off to the side, but don't sit and stare and dig around. That also can feel really like vulnerable.
Yeah.
And so fingers are in, and then if they ever say no, they stop, whatever, that's a no. And then you take your hands out and be like, what can I do to make you feel more comfortable? You know, I'm so close. I find it sometimes too, like, especially for a hard exam, they'd be like, and I'd be like, breathe through it. I know, I'm so sorry. I'm so close. The cervix is really high. This is going to get easier. You're doing so amazing. Like, stick with it, you know. And this is if they're not saying no, stop, whatever, like kind of powering through it. And you know, it's a hard exam where you're really having to reach up far. And again, they say stop, hands out, you wait, switch your glove, let's try again. Like, there's very few circumstances, and it does happen, where there's an emergency where we're like shoving our hand up there and I gotta find the cervix, you know, and obviously like cord prolapse or, you know, like those kind of things. Even in those moments, it takes 1 second. I have to check your cervix. We're very concerned about the heart rate. I need to know that everything's okay. Is that all right? Yes. Fingers in. Like, you don't have to, okay, open your knees. Now take a deep breath. Like, in an emergency, obviously we're flexing and flowing, but for the most part, 95% of the time, to give an extra 3 minutes on your clock can make all the difference for their experience, and it makes your exam easier when they're resisting you. Like, how many times do you have to be like, okay, drop your butt, like,
Right.
okay, let's reset, like, and then it takes 5 minutes when like you can go in, pop your fingers in, and oh, all right, you're 380 minus 2.
And it
It
helps just build your rapport for the rest of your
totally,
shift and all your other exams too, which is great.
totally.
What was the thing that Krista said? If and people that don't know her, Krista Dancy is a trauma therapist that is amazing, and we offer one of her classes in mentorship, and she's going to be in Cancun. She mentioned,
There are 4 of her classes on our site that you can
yes,
purchase right now to become more trauma informed from a perinatal psychologist. That's amazing. They will blow your minds, by the way.
yeah, so trauma level 1, trauma level 2, grounding techniques, and then healing trauma for the birth professional, which is my personal favorite. But she said something during when she was teaching the classes about the patient. You'll explain the story better. I know you that remember the story I'm
Hmm.
talking about.
Yeah,
Take
I
it away.
think this was one of like the most impactful things that when we were filming those classes for you, I was like, "Oh my God, you are
Yeah.
so right." And the idea was that for us, we are so comfortable with vaginal exams, with painful procedures. We're so comfortable with moans and groans and like it's supposed to hurt. Like, of course, like we're not maybe, and I don't want to speak for everyone, but like in comparison to maybe some other people, we're kind of like callous to the like experience of pain.
Well, and we hear pain and we're like, ooh, good. We always
Right.
joke like we're the only people that want pain, because it means
Yes.
something's happening. Yeah.
Yes. And so with that being our baseline, that for the patient, they are not, and they're not
Mhm.
used to that same like level of comfort with pain. And so for them, there's a miscommunication a lot of times happening with no and stop, because for us to hear no, right? Or like ah, or ooh my God, oh my ooh, ah, where they're freaking out, we're like, okay, suck it up. Like that's just how it goes,
Yeah.
For them in their minds, when they make those noises or they pulled away or I flinched or I resisted or I was like, ooh, that's a lot, and they didn't stop, for them, they were meaning stop, but they
Mhm.
didn't use the word stop. And for
Mhm.
us, we heard, oh my God, ooh, no, geez, oh my God, pulling away. And for us, we're like, well, let me power through it and get this thing done. And so there's a miscommunication where for them, they meant no, stop, and we didn't stop and they felt violated. And trauma can happen. And so instead, it's
And they went to see a
establishing,
trauma therapist.
oh yeah, oh
So
yeah,
like,
like life impact to
right.
the point where they're seeking support because of those moments that we do not mean to have.
Mhm.
And so this is where if we can be over communicators related to our vaginal exams and say like look you in the eye and say, listen, when I check you, if you ever don't want me to continue and you want me to stop, I need you to say the word stop. If you need to moan, if you need to like breathe deeply or like wince, when you resist, it makes it harder and like it takes a little bit longer. So I want you to try to relax through it. But if you use the word stop, that is a hard stop. My fingers are out. We are done. Okay? And you make that agreement between the two of you so there isn't miscommunication. And then if they say stop, you stop. And that is paramount. Like you can't push through that. You cannot.
Yep.
If they say no, we are not assaulting our patients. And that's what it ends up becoming if they've said no and we continue.
Yep.
I know that's intense, but like that's the truth.
And if you're watching an exam happening and they're saying no, out, no, and we're standing there, our words are saying, she's saying no, they're saying no, and encouraging and advocating for our patients in
And
that
just being
sense.
strong, yeah, like looking at the provider and saying the provider's name and saying, she's saying no. And kind of like, you need to get this or you need to stop.
Yeah.
And I would go so far. If you're watching this and you know this patient is maybe not using the word stop, but like it's not okay what you're seeing, is to the provider, they're saying no, you need to stop.
And if they don't stop, then you need to escalate that. You need
Yeah.
to write them up, do what you need, your steps with your hospital. That needs to be reported. It can't
Mm-hmm.
be not reported anymore. We have
Mm-hmm.
to end this cycle.
Mm-hmm. Yep.
So this
Whew.
started all like fun,
I know. And now I'm like,
laughing, like,
oh.
ooh, oh, dang. So sorry, guys.
Take a deep breath. But
Go
guess
find
what?
your hole in the bowl.
Oh, go. And know that we can protect these patients. This is trauma-informed care. And this is why you need those classes. This is why this education on this podcast, this is just barely scratching the surface of all the ways that we can just develop a practice that not only is trauma-informed, but that protects our patients and their psyche, their experience, and builds a relationship where they walk away feeling whole, complete, loved, cared for, successful, empowered, all those things that we want for our patients.
Thanks for spending your time with us during this episode of Happy Hour with Bundle Birth Nurses. If you liked what you heard, it helps us if you subscribe, rate, leave a raving review, and share this episode with a friend. If you want more from us, head to Bundle Birth Nurses or follow us on Instagram or TikTok. Now it's your turn to take what you learned today, ask for consent, protect your patients, find those holes in the bowls, and let us know how it goes. Let us know if it gets easier for you after this episode. We'll see you next time.